Hi, I'm Dennis Hart. I'm a pediatric rehab physician from Joe DiMaggio Children's Hospital down in Florida. I feel like my talk's already over because Dr. Bloom has talked about empathy and listening, and Dr. Rudin, I was surprised to hear there was another rehab physician. I want to present actually a shout out to us because I feel like we're the perfect physicians to really help with this. And then Dr. Gaskin just made me nice and relaxed with the breathing exercise. So I have nothing to declare. Most of my talk's going to be about trust and mistrust. We're going to talk about what causes physician breakdown, review the drivers of trust, and then we'll talk about some of the models of medicine and how some of those models have actually been barriers for this type of population. So again, I'm a pediatric rehab physician. We treat a wide variety of things: brain injury, spinal cord injury, chronic pain, and my big interest is in chronic pain. But we also focus on function, which is really one of the issues that many people with EDS have to deal with, is how do they get around in the community without worsening their chronic fatigue or worsening their pain. We also interact very closely with the therapists that are often the people that are actually guiding the patient. We collaborate with a lot of disciplines. One of the things that I find interesting, I've been doing this where I've seen a large population of EDS patients for about 10 years now. And in most cases, when they get to me, they've seen the orthopedic surgeon, the neurologist, the neurosurgeon, the geneticist, and oftentimes many other doctors before they actually get to me. And I'll explain that as we go on. The other important thing is, I think more than any other group, except maybe the integrative medicine and the functional medicine doctors, we treat the whole person. There's no way that you can separate the mental health and the physical health of a patient. And if you don't understand the interaction between the two, you're not going to be successful in treating that patient. So there are two things that when I first started looking at this and I was reviewing the literature, one was a saying that came up, and then the other one is a title of an article. And the first one is, the patient will never care how much you know until they know how much you care. And I fully believe that. I think it's very important that you need to reflect to them that you're in it to help them. You're not in it for the money or what a lot of people assume doctors are in it for. The second one is, this is an actual title of an article: Recommendations from the Twitter hashtag Doctors Are Dickheads, Qualitative Analysis. And it's really true, and I'll talk about some of the findings in that article. So to start off, we have to define trust, mistrust, and distrust. We won't talk much about distrust, but trust is believing in something or someone. Very simple definition for that. Mistrust is not just the absence of trust. Mistrust is based on an uneasiness or wariness that's due to intuition rather than knowledge, versus distrust, which is you have informed opinion and knowledge or experience that makes you distrust the person. I see distrust and mistrust on a regular basis between physicians and patients. And understanding a little bit more about how that works can go a long way in terms of dealing and getting the right position with your patients. Many of the patients that I see, they come into me with mistrust mainly because of the 5 other physicians that they saw beforehand. And so I work very hard on establishing that relationship. Let's see if I can go back here. Historically, I'm just going to point out the figure here. Historically, the vast majority of the research on trust and mistrust in medicine comes from the African American population. There are starting to be some articles on diagnoses, including Ehlers-Danlos, on mistrust, but there's very little actual data to look at that. So mistrust in medicine is not always the patient mistrusting the physician. These things happen in both ways. Physicians often don't trust themselves because they don't have adequate knowledge. They don't trust their colleagues because their colleagues often don't believe in the diagnosis. Certainly, our healthcare system, in my opinion, has things very backward. They give primary care physicians 15 minutes to see a patient. How can you possibly establish a good relationship with your patient in 15 minutes? Especially with somebody who has a lot of chronic healthcare needs. And then society, there's a lot of mistrust in our society of the healthcare system. I have a lot of patients who come in who they're looking for answers, but they don't want the medicines, they don't want the things that healthcare offers them because they they mistrust it. They'd rather trust what they read on the internet than what our healthcare system presents to them. And it's because there's history behind that. People know that our healthcare system's not perfect, and they often there's a bias. There's a bias toward pills rather than treating with natural things. There's a bias toward financial incentives. There's a lot of reasons why we mistrust society. And you have to figure out as a physician what's their underlying mistrust. Is it specifically with the system? Is it with your particular system? Or is it society in general? Excuse me, if I could get some water. From a physician perspective, actually, thank you. From a physician's perspective, Dr. Rudin has already kind of implied this. I think some of the other people have also implied it. There's been paternalism in healthcare for many, many years. Doctor knows best. Doctor is God. And believe it or not, that for a lot of patients or a lot of physicians, that hasn't left. There are still a lot of physicians that get very angry when their patient tries to give them information that they don't know. And so we have to deal with that. We have to deal that in training. I love the fact that you're doing that in fact, I want to come work at the University of Wisconsin. It sounds like a much better place than I'm in. So the other issues that physicians always think about, it's bombarded with them, malpractice risk. That's actually getting worse because now, in some respects, with these guidelines that we're developing, physicians are afraid to step out of their zone. And so I have rheumatologists where if there aren't red hot swollen joints, they are not going to treat it. And that we can't do that. We need to have that broader vision with chronic care, people that have chronic health care needs, including EDS. I'll tell you, lack of emotional intelligence is a rather big one for physicians. We're though, in many cases, that white male who has a lot of privilege, and when you grow up like that, you don't really learn emotional intelligence, and we don't teach emotional intelligence in medical school. At least they didn't when I was in medical school. I think the last number I saw was 60% of physicians are burned out. And so they aren't paying attention because they're tired and they're thinking about other things. Many of the physicians, when it comes to chronic illness, they feel like they've had negative patient experiences because they had difficulty with communicating with the patient. 15 minutes for a visit is not adequate time. Some people, I don't know why physicians think that they're not reimbursed adequately, but some of them think that they should be reimbursed more. There's a lot of lack of appreciation because we are still in that mode of there's too many problems that you have. It can't all be related to one thing. That's a theme I hear from a lot of physicians. No-show rates make it hard for them to keep a clinic busy. There are some patients that are entitled and they feel are entitled and they don't like dealing with them. That's a communication issue as well. And then there are, unfortunately, patients that lie to their doctors. But I can tell you there are as many doctors that lie to their patients as there are patients that lie to their doctors. So from a patient perspective, this is one of the things that came out of the study with the hashtag was 25% believe that they spend too little time with them. That's a societal thing with physicians. Physicians are driven by how many patients they see, in most cases, at least in the United States. They don't know me, and I'll talk more about that. To me, that's one of the most important things. They don't listen to me. They don't give me all the information. Some people are financially motivated. Some of them don't make eye contact. There are socially inept physicians. In fact, most of us are nerds, and a lot of us are socially inept. So, and then there's quite a few other patient perceptions out there. I'll stop here, and I just recently saw a patient that has been a patient of mine for quite some time, and I spend a lot of time with her. She has a lot of emotional issues, but nothing that doesn't go along with having a chronic illness. But one of the other physicians referred her to one of our palliative care doctors, because they sometimes see some of the chronic pain patients where I am. And she came out of that. This palliative care doctor is a good doctor. She understands a lot of what's going on with chronic pain, but she didn't really listen to the patient. And she came back to me, actually it was the next day I saw her, and we got to talking about these exact things. And she said that they don't know me. She doesn't know me. She didn't want to listen to my story. And a theme throughout my talk here is going to be, you need to listen to the patient's story. You need to give them time to talk about what their issues are. And then you need to figure out how do you solve those issues, and what the deeper meaning of those issues are. Because a lot of times if they say, oh, I have joint pain, that doesn't really explain what's going on with them. They have joint pain, yes, but they can't get around school, or they can't do their work. And the goal isn't necessarily to take the joint pain away. The goal is to help with their functional daily life. So patient perspective, they believe, and rightfully so, that the patient's experience and knowledge contributes to medical error and harm. I've seen that done. I've seen patients come in with mast cell disorders that had totally inflamed guts, that they were admitted to the hospital, they knew something was wrong, but they would not take that step forward to really try and understand what was going on. Physicians gaslight a lot. They will often make the patient feel as if their problem is not real. Egotistical and dismissive behavior is a common thing, especially when patients get admitted to the hospital. I found a lot of hospitalists, they look at this as conversion disorder or something else, and they aren't willing to open their mind to what it may be. And so I actually try and keep my patients out of the hospital because they get treated very poorly, both in the ER and when they get admitted. Let's see, sorry. Professor Bloom mentioned power of inequity between the patient and provider. The fact is that a lot of physicians are of privilege. Most of them have not come from poor backgrounds, and they're neurotypical, they're cisgender. You as a physician have to be aware of that privilege and understand that the things that are going on, you have to look beyond yourself and put yourself in the patient's shoes, not look at how it affects you. And a lot of physicians, because they aren't emotionally equipped, don't do that. So there are a lot of factors that contribute to challenging interaction. Patients can present with long lists of symptoms. How many of you have presented with long lists of symptoms? It's because you have a lot of symptoms. You have to document those symptoms, and you have to understand how those symptoms relate to the patient's life, and not just try and treat a symptom. A lot of this is listening is a big problem. Oftentimes, diagnosis, unless you're somebody that's willing to make the diagnosis hasn't been established. They're afraid that you're gonna want drugs, or if you decrease a drug, I'm gonna skip forward there. So from a physician's perspective, it's a lack of confirmatory tests. There's a lot of extreme variability. I have patients where I have 4 people from a family, and they all present very differently. There's no good consensus. It's really, in many respects, an invisible diagnosis, unless you know what you're looking for. And then we are, Professor Broom already said this, we are taught to listen and look for horses, not zebras. From a patient perspective, there's general disbelief of people when they realize the physician doesn't know much about it. Physicians often think it's psychosomatic. And then there's a lack of medical professionals that actually deal with this. So quickly, there's kind of 4 models, and what we're trying to do is bridge the gap between the models. Old model in physician is the paternalistic model. I treat you. Then there's the informative model where I educate. And then there's the interdisciplinary. The goal is for us to have an interaction where you understand your preferences, and then you understand my preferences, and we work together to come to a solution. So I'm gonna skip through because I've already used up my time, but the 3 drivers of trust are empathy, logic, and boy, I can't read that. Authenticity. The authenticity is the hard one to address. But these are the things you can do to build trust. Listen actively, help them deal with overwhelming information, encourage the patient to seek second opinions, invest in your team, and stay up on your research. With empathy, there are all these things that can cause empathy to decline. I won't go through all of them. Again, physicians are not trained in being empathetic, and I think we need to do better with that. Often with training, you need to start out with cognitive empathy, which talks about their experience perspective, and then go to affective empathy, where you really understand the emotion involved. And oftentimes you end up needing to have a therapist involved. I often use medications because I screen for depression and anxiety in every one of my patients. These are all the things in terms of listening actively that I think are really important. And then there are barriers to active listening. Distraction, emotion, preconception is a big one with physicians. They often come into an appointment when they review the chart and have a preconception about the patient. There are ways to reduce the barriers. The main thing to me is listening to their story, because that gives you a better understanding of the direction and the path that they're on. I'm going to skip. Managing overwhelming information really comes about through communication, being willing to talk to them about what they've learned, because many times I'll have patients come in who already know more about Ehlers-Danlos than I do, and you need to be able to listen to them, critique the information that they have so they know what is adequate information and what's not. This is a two-way street. You need to plan your interaction in advance and then discuss it and get educated if you need to. And then bridge communication and trust. Authenticity is the hardest thing to really define. But the fact is that if you don't go in and present that you are there to help and that you're interested in what they have going on, they're never going to trust you to make qualified recommendations. Inauthenticity leads to physician burnout. It actually leads to lack of self-esteem in physicians, and then obviously patient trust. So the conclusions for the physicians. First, treat the patient as people first, conditions second. Listen to their story and be engaged in their issues as a partner. And then one of the important ones, this is one of the findings from that hashtag article. If you don't have a clue with what's going on, just say so. Tell us you don't know, and that's all. And then be less defensive and listen to critiques from the patients. If you're not having those kinds of interactions, the patient's not going to trust you. You need to address your burnout. We definitely need to improve our empathy, and that's something where we need more education in medical school, residency. So we need to change our attitude to let the buyer believe rather than let the buyer beware. Conclusions for patients: be honest in your expectations. Know what you are going into the meeting or to the appointment wanting. Prepare your story ahead of time so that you don't ramble through your story. Openly share information that you get from the internet and other places so that the physician can have a conversation with you about the significance of that. And don't be afraid to ask questions, but be respectful of their time, because Professor Bloom made the comment that time is something we have and it doesn't cost anything. And I would argue with her from a physician standpoint, because the reality is, in most cases in the US anyway, physicians are being driven by their billing. Nothing I can do about that until we change to uniform health care. But so a lot of times physicians are worried about how much time they're spending with a patient. And so don't just assume that they're going to spend however much time with you. If you have to, break your issues up into several spots if it's a physician that's not going to listen to the whole story. But my most important suggestion is for the patient or for the physicians to really learn from the patients and listen. Thank you.